In order to talk about any public health issue, you should have some facts about current trends in the problem in the population of interest, in this case, Scotland. And we're lucky to have with us today Helen Sweeting from the MRC's Social and Public Health Sciences unit in Glasgow. Helen originally trained as a psychologist, clinical psychologist, and has made a kind of a specialty out of understanding what the available data can tell us about trends in risk-taking behaviors of various sorts in our population, in this society. So, Helen, welcome.
Thank you. As John said, I'm going to be showing you figures and numbers. They're the results of analyses of data from two cohorts of adolescents who were surveyed either side of the 1990s. So my main focus is on time trends in the data. You've just been thinking about the media, and I have to say that a journalist picked up on these. There are two papers. I sent her the papers. We discussed the results in quite a lot of detail. It appeared as a very tiny piece in the Sunday Mail a couple of weeks ago, and the headline was "Shocking Rise in Underage Sex." And you can see if you think that that's a fair statement to what I'm going to say. My talk is based, as I said, on two recent papers. I'd like to acknowledge my co-authors, Caroline Jackson and Sally Hoare. They were both sometime members of the Scottish collaboration who are hosting this event. Caroline's now based in Brisbane. Sally's also moved, but she's only gone to Stirling. So I mentioned there have been two papers, so I've split my talk into two chunks. The main focus of them both is on time trends, but part one looks at trends in the actual risk behaviours themselves, and part two looks at relationships between the risk behaviours and how those might have changed over time. So, our understanding of time trends in health risk behaviours among young people mainly comes from repeated cross-sectional school-based health and behaviour surveys. But that actually raises a number of problems when it comes to comparisons over time. First, surveys often include different age groups or different behavioural measures. But even if these differences are only very slight, it's possible that they are the reasons for any variations found in rates. We also know much less about time trends among older adolescents or young adults. And that's mainly because they're not tracked in school, having to take part in surveys. And that means that analyses on these older age groups may be limited by small numbers. And they also often use very broad age categories, such as 16 to 24 years. But we all know that there are absolutely massive differences between young people at either end of this age spectrum. So lumping them all together would mask these differences. So what do we know about time trends in older adolescents? First, as with younger adolescents, there was a reduction of gender differences in smoking, drinking and drug use during the 1990s and into the new millennium. And in fact, in some northern and Western European countries, a female excess in smoking prevalence emerged. Second, in respect to sexual risk behaviours, a UK-wide survey of sexual attitudes and lifestyles reported an increase in early sexual initiation among females up to the mid-1990s, after which the rates appeared to stabilise. So what about our study? Well, it describes changes between 1990 and 2003, so over the course of the 1990s, in rates of late adolescent smoking, drinking, illicit drug use, and sexual risk behaviour. It uses self-report data from two West of Scotland studies, and importantly, given the problems that I highlighted earlier about making comparisons over time, these two studies surveyed participants from exactly the same geographical area in and around Glasgow. The participants were of almost the same age, and that age was within a very narrow age band. and the studies used identical or virtually identical self-report health risk behaviour measures. And what this means is that any differences found between the studies can more likely be attributed to real changes over time rather than methodological differences between the studies. So just a bit more. The study looks at changes in rates between 1990 and 2003 overall, so among all young people, and it also compares males and females and those of higher and lower socioeconomic status. We used at least one measure of each behaviour, and this is important, and it's because previous analyses show that the patterning, the socio-demographic patterning of substance use differs according to the measure that you use. So, for example, we've shown that while occasional smoking is more likely among those from higher SES groups, heavy smoking is more likely among those from lower SES groups. And similarly, cannabis-only users are very different from those who use other drugs. Now, that might seem really obvious to you, but most studies have one measure of smoking, which is just smoking. They often have any drug use, and that's it. You can't really tell much from that. Another thing which our study does is it checks whether even very small age differences impact on health risk behaviour rates in older adolescents. And finally, it uses multivariate analyses, sorry, it's a bit complicated, to try and take account of age, gender, and SES differences between the cohorts, which again means that any differences found between them can more likely be attributed to real changes over time rather than to sampling differences between the studies. So our data sources were the West of Scotland 2007 study and the West of Scotland 11 to 16, 16 plus study. They're both MRC funded studies. I won't go into much detail about them. 2007 began in 1987 and its youth cohort at that time were age 15. And they were followed up in 1990. And I'll be referring to this as the earlier or the 1987-1990 study. 11 to 16, 16 plus began as a schools-based study. It surveyed participants at 11, 13 and 15 and after school leaving. And I'll be referring to that as the later or the 99-2003 study. For statisticians among you, I've used weighted data in these analyses. You can see the weighted numbers up there, about 900 in the earlier study, 1,000 in the later one. This section of the talk, which is about rates, uses data gathered at age 18 to 19. And the second half, which is on associations between behaviours, also includes some data gathered at age 15. So these are the measures used in our comparison of health risk behaviour rates over time. 2 measures of smoking, current, so that is any smoking, and heavier smoking. 2 measures of drinking, which is excessive weekly drinking and binge drinking. These are both based on standard definitions. 4 measures of drug use, so any drug use at all, any drug use within the past year, and then use of cannabis only in the past year, and use of any other drugs with or without cannabis in the past year. And 4 measures of sexual behaviour. Sexual initiation recalled as having been at age 15 or less, having had 3 or more partners ever, 2 or more in the past year, and having ever been, or for boys, made anyone pregnant. So I'm going to start by showing you the rates of each behaviour in the 2 cohorts. The earlier cohort, so they were 18 in 1990, are black, and the later cohort were in 2003, they're grey. So first, smoking, and you can see that rates of current smoking remain stable at around 33%, but rates of heavier smoking dropped from about 22% to 16%. Now I've added in drinking, and you can see increases in both excessive weekly drinking from about 20 to about 30%, and in binge drinking from about 35 to 45% between 1990 and 2003. And now here are the rates for the 4 drug use measures at each date. You can see massive increases in them all. Any drug use pretty much doubled, and any last year went up from about 25 to about 40%, and there were similar rates of increase for cannabis only and for other drugs. And here are the sexual risk behaviours. Again, big increases, in fact, a doubling of them all, except, and this is important, pregnancy, which didn't change much. So that's overall, but what's the picture if we look at males and females separately? So here I am, I'm using traditional colours because it's easier for males and females. Got 1990 rates darker and the 2003 rates paler. So here's smoking, and you can see that actually the only, I don't press anything now, which was the light one? It doesn't matter. I think you can see. Oh, right. Square at the top. Oh yes, there you are. So that's the only difference, okay, in reduced rates of heavier smoking among females. Now, I've added in drinking, and what you see is that, again, it's not the males, it's the females who've changed. So massive increases in both excessive and binge drinking for them, very small increases for males. Here are the male and female rates for our measures of drug use. And what you see is that although the increases, again, were larger for females, for whom the rates of all these measures pretty much doubled, the male rates also increased significantly over time. And finally, here are the male and the female measures of sexual risk behaviours. Okay? So of early sexual initiation, 3 or more partners ever, 2 or more partners in the last year, and having ever made anyone pregnant or being pregnant yourself. And you see here the gender difference is even clearer. There were increases among the males, but among the females, rates of early sexual initiation were about 3 times higher in the later cohort. Having had 3 or more partners was about 5 times higher. 2 or more in the past year, about 4 times higher. You can see a small increase in pregnancy rates, but I've got more to say about that in a minute or two. So, now I'll give you something else to think about. And that is that there was an 8-month age difference between the cohorts. So the later cohort were just a little bit older. They weren't much older. In almost all studies, they would be just regarded as young adults. They would be regarded as the same. But we did some analyses which showed that the age of our participants was positively associated with several of the risk behaviours. And that, again, that's probably not surprising. But as I say, it's not something which most studies would take into account because they'd just assume everybody was the same. But it leads to the question, might some of the observed increases in rates just be because the later cohort were a bit older? And if you're older, you're more likely to do these things. And the answer to that question is yes. But it didn't account for anything like all the difference. Now what I'm going to do is I'm going to show you the results of multivariate analyses which stick age into the analysis. They adjust for that age difference. So they take account for that. They also take account for of social class differences, but don't worry about that too much. So these multivariate analyses show the odds, the likelihood of each behaviour in 2003 compared with 1990. There's a line at 1, because if the adjusted rates of a behaviour in 2003 were exactly the same as they had been in 1990, then that would be an odds ratio of 1. If rates increased, you'll see a bar going upwards from 1, and if they decreased, you'll see one going downwards. And the scale might look a bit odd to you. It's logarithmic. So the odds go from 10 times more likely at the top to 10 times less likely at the bottom. And again, I'm going to start with results for the whole sample. So we are adjusting for age. And here's what happened for smoking. You can see the decrease in heavier smoking, which we know about. And actually, even though the rates of current smoking didn't change over time, because the later cohort were older, and those who are older are more likely to be smokers, our results now show that after adjusting for the age difference between the cohorts, there was also a slight decrease in rates of current smoking. So hooray! Right, here's drinking. And as I say, that difficult with the logarithmic scale, but these odds, that's 2, 3, 4. So these odds are about 2. So about twice as likely, excessive drinking and binge drinking were both about twice as likely in 2003 compared with 1990. Here's drugs. The odds for any drug use in 2003 compared with 1990 was around 3. Okay. And here's sexual risk behaviour. Again, clear difference here compared with the simple unadjusted rates. And you'll remember those showed higher rates of pregnancy in the later cohort, but that increase completely disappears after accounting for the fact that they were a bit older. So they were engaging in more sexual risk behaviours, but pregnancy was not more likely. Now, very quickly, the same for males and females. Here's smoking, with the big decrease among females, and the stars show that that was a statistically significant difference between males and females for this. Here's drinking, massive increase for females, almost none for males, and again, significant gender difference. And drugs, and here, although the increases were larger for females, the gender differences weren't actually significant. Even this one wasn't significant because it's based on quite small numbers who were using other drugs. And finally, sexual risk behaviour, very large increases, but only among females, and as I said, not in pregnancy. So that's covered the gender differences. And we also looked to see whether rates had changed differently for young people from lower compared with higher socioeconomic status backgrounds. And we found similar results for this, whether it was represented via social class or area deprivation. And I'm going to show you the results for deprivation. So here we have young people from less deprived areas in black, okay, and from more deprived areas in grey. And you can see that current smoking only dropped among those from the less deprived neighbourhoods. Increases in drinking and sexual risk behaviours were larger among those from more deprived areas. Though these differences weren't actually significant between the areas, but generally they're larger among those from more deprived areas. But for drugs, this is really interesting. The increases in any use and any use last year were the same, regardless of whether the young person came from a more or a less deprived area. But what's important and interesting is that increases in past year cannabis only, which is this one, were greater among those from less deprived areas, while increases in the arguably more risky other drugs were greater among those from more deprived areas. Now, this difference would be masked if you only used any drug use in the last year, which is what a lot of studies do. You only notice it if you split it up. So, to summarise the first part of my talk, first, age really needs to be considered in analyses like these. So, for example, after accounting for age, an apparent increase in rates of pregnancy disappeared. Second, rates of each risk behaviour, apart from smoking and pregnancy, increased massively over what's a relatively short time period, only 13 years between 1990 and 2003. Thirdly, these increases were generally much greater for females, especially for drinking and sexual risk behaviours. Rates of many of these behaviours actually barely changed for males. Increases were fairly similar for those from lower and higher SES groups, but there were some key differences likely to increase inequalities in health. So smoking only decreased among those from higher SES backgrounds, and there were differences between the groups for increases in cannabis compared with other drug use. So that is the end of the first part of my talk. The second half is shorter, so it's not a half, it's less than a half. So, part two. This part is looking at relationships between the risk behaviours and whether these differed between the cohorts. Just as some background to this, why were we bothering to look at this at all? There's a lot of evidence, actually, that some health risk behaviours tend to cluster together in adolescence. And a major focus of the work looking at this has been on relationships between substance use and sexual behaviour. And the issue is, why does this occur? Well, it probably occurs partly because of the direct effects of certain substances, basically alcohol and drugs, on sexual decisions. But since not only alcohol and drugs, but also smoking, which doesn't tend to make you disinhibited, I don't think, is strongly associated with adolescent sexual risk behaviour, the literature also suggests that this clustering probably reflects a predisposition towards risky behaviours in some individuals. And if clustering reflects a predisposition towards risky behaviours in some people, then might clustering change when risky behaviour rates change? Okay, so why might we think this? Well, studies have examined differences in clustering by other things. So they've looked by gender, and they've usually found weaker associations among males. And one of the suggested reasons for this is that sexual experience in adolescence is more common among males. Well, at least it was until recently. And this means it's kind of more normative. And so the suggestion is that it's less tied to other problem behaviours for males. Studies also looked by country. One study looked at between country differences, and it found weaker associations in the United States than in Europe. And the authors of this study said, well, maybe this is because of lower substance use rates in their American sample. And so again, it's, they're sort of saying there's something different in the actual rates, and that's impacting on how they cluster together. And one study which found no associations between substance use and sexual risk behaviour at all was looking at what they described as urban, impoverished African-American adolescents. And they said, well, maybe these behaviours just have different cultural meanings among certain groups. So there's evidence for differences between certain groups in the ways that health risk behaviours cluster together. But there hasn't been a study on whether clustering changes over time. So the main question for our study was, are associations between substance use and sexual risk behaviour more or less evident when those risky behaviours are more prevalent and so arguably more normative? We also looked to see if clustering varied according to age, which again is something which other studies haven't looked at. And our data meant we could look at how health behaviours clustered at both younger, so middle teens, and older adolescents. Secondly, do the associations between substance use and sexual risk behaviour vary according to gender? As I say, previous studies would lead us to expect stronger relationships among females. And something else also not addressed in other studies is, do the associations vary in different socioeconomic groups? Now, our data come from the same two cohorts. Because we were interested in the way that behaviours cluster together, we had to go back to rather sort of dull, wishy-washy measures, really. We had to pick measures of substance use which were relatively prevalent, because otherwise we couldn't have done the analyses because the numbers would have been too small. You're familiar, because I've talked about them, with the older adolescents measures. In younger adolescents, the measures we used were having started smoking at age 13 or less, monthly drinking at 15, and any drug use, and sexual initiation at age 15 or less. And you know from part 1 that the rates of each of these behaviour, except smoking, increased over time among older adolescents. Here are the rates for each of the 4 younger adolescent behaviours among males and females in the 2 cohorts, just to show you really. Again, stereotypical colours, earlier cohort darker, the later one lighter. You can see no change in the proportion who started smoking at age 13 or less. Monthly drinking and drug use increased massively, more so for females. And as we've already seen in part 1, rates of early sexual initiation increased really only for females. And just as a reminder, really, here are the behaviours you've seen in part 1. No change in current smoking, increases in the other behaviours. So the question is, given the big increases in rates of drinking, drug use and sexual risk behaviour, particularly among females, were there changes in how substance use and sexual risk behaviour clustered together? And if there were, did these changes differ for males compared with females? Now, I'm going to be showing you the associations which smoking, drinking and drug use had with sexual risk behaviour. And I'm starting with associations between younger adolescent substance use and early sexual initiation. I'll be showing you mutually adjusted associations. In other words, they're all adjusting for each other. And I guess in yet more other words, they're independent of each other. And these analyses also adjust for social class and for age where that's relevant. So the way I'm going to show you these is as odds ratios. Again, we've got a logarithmic scale. It's going along the bottom now. And so if a substance is positively associated with early sexual initiation, the odds ratio will be above 1, and if it's negatively associated, the odds ratio will be below 1. I'm going to start with males from the earlier cohort. I'm going to show you little blobs with lines which are 95% confidence intervals for the associations between the links between each substance use and early sexual initiation. So here they are. And this shows that in the mutually adjusted model, the odds of early sexual initiation were about 2.5 times higher among those who'd started smoking at age 13 or less, around twice as high among those who were monthly drinkers at 15, and about 2.5 times as high among those who'd used drugs at 15. So we've got strong clustering, which is what other studies find. The question is, does that clustering change over time? Is there a difference between males and females? So now I'm going to add in the males from the later cohort. And you can see that actually they're pretty similar. And even in the association with drugs down here, which looks a bit different, the 95% confidence intervals have a big overlap. So there's no way that these blobs are statistically significantly different. So what about females? Here are the results from the earlier cohort. There does look to be a weaker relationship between smoking at earlier ages and early sexual initiation, but still the confidence intervals are overlapping with those of the males. Last of all, females in the later cohort, there are some differences here. So there's a cohort difference. So the females in the later cohort, stronger association between early smoking and early sexual initiation, and also a significant difference between males and females in the later cohort in the use of drugs and sexual initiation. But actually, if you look at the picture overall, there is no clear pattern of difference, either by cohort or by gender. And here's the same thing for the older adolescent behaviours. So relationships between substance use at age 18 or 19 and having had 3 or more sexual partners. Here you've got males in the earlier cohort, males in the later cohort, females in the earlier cohort, and females in the later cohort. Again, one significant difference, but no clear pattern of differences either between the cohorts or between males and females. And finally, some results I'm not going to bother showing you on a slide, but they were that when we looked separately for non-manual versus manual social class differences, rather than by gender, we also saw no obvious differences. So to summarise part 2 of this talk, we found strong associations both between younger adolescent substance use and early sexual initiation, between older adolescent substance use and having had multiple sexual partners. We found that these relationships were broadly similar for males and females and between social class groups. And importantly, despite much higher rates of drinking, drug use and risky sexual behaviours, but not smoking in the later cohort, relationships between use of each of these substances and risky sexual behaviour showed little or no change over time. So what are the implications of this? I was really hoping that Harry would have left because I've realised this says targeted on, so I can, I've got a bomber's slide and I apologise for that. And actually, of course, what I'm going to say here is just what has been said many, many times before. First, a high prevalence of adolescent risk behaviours shows we need to improve interventions designed to prevent uptake. We haven't got a study of older adolescents from 2011 to update this analysis. There have been some slight changes, but we know there haven't been massive drops in these rates. Second, because risky behaviours are so widespread, actually, there's got to be a balance between universal policies which cover all young people, that is important, and those targeted at more vulnerable groups. Thirdly, policies should actually take advantage of the fact that risky behaviours cluster. So rather than siloing everything off, sexual health clinics could routinely, opportunistically offer advice and counselling for alcohol and illicit drug use. Stuff could all happen together. Fourthly, part of the reason that risky behaviours cluster is that they have shared underlying determinants. So, and of course, I recognise how easy it is to say this and how difficult it is to do, but preventive approaches really need to aim to address these broad determinants. Fifthly, since we've shown both high rates and strong associations between younger adolescent substance use and sexual initiation, this means preventive measures should be implemented at younger age, probably starting during primary school. And finally, of course, and it's not on the slide, what much of this needs is just effective cross-sector collaboration, especially probably between education and health departments.